Thank you, everybody. It's really nice to be invited to give the winter lecture, as if we don't have enough real-life reasons to remind us that it's winter in Edinburgh. Today I'm talking about controlling NTDs in the post-MDG era, which is quite acronym-heavy. Unfortunately, the talk will be a bit like that because a lot of what I'm talking about, the organisations, institutions which shape policy at a global level and how that translates down to a practical level within Africa. But first I'd like to start off with a picture. This is Chris Froome, for those of you who don't know much about cycling, and this is him winning the Tour de France earlier this year. And I did a bit of social scientific research. I did a Google search of news stories about neglected tropical diseases, and Chris Froome was the #1 story for the first 6 or 7 months of this year. Chris Froome actually was born in Kenya. He grew up in South Africa, was raised in South Africa, and became British, I think, when he became quite good at cycling. And the big news story is that he is a long-term sufferer of bilharzia, of schistosomiasis, which has been kind of touted in the press as the reason for his kind of quite remarkable rise. He was kind of a middle-of-the-road cyclist in South Africa. Then about 2 years ago, it was discovered he was infested with schistosomiasis, and since then he's become really, really good. And I think that speaks to all sorts of key issues about the NTDs. The kind of really unknown. If the cyclist, who is partially British at least, is kind of the poster person, the poster boy of NTDs in the UK, that says quite a lot. And if we look at some of the text we can see from newspapers as well, the way in which it was reported, I think, says quite a lot about how we perceive the NTDs. Chris Froome battles the enemy within. The rather obscure parasite, although according to Independent and The Guardian, it was actually a virus that acted like anti-EPO. So basically, because he was infested for his whole life, he developed really good kind of ways of coping. And when he was freed of the disease, he became a really excellent cyclist. And of course, as probably everybody in this room knows, it's not such an obscure parasite at all. 290 million people are infected globally. And it's a real tangible thing. It's not just an abstract thing which is talked about to try to decide whether Chris Froome may not be on performance-enhancing drugs. So I think we have a sense that NTDs haven't yet reached the public consciousness, but certainly I think there's a sense that they're becoming much more of a global policy idea. And I think it's quite interesting to look at how that's happening and why that's happening and what that will mean as we approach the end of the MDGs and we head off into the future beyond that. And I think there are ways, that the things we can look at which help us get past a lack of knowledge, a lack of awareness, is other sorts of global campaigns. Make poverty history, debt justice, trade justice. There's kind of global lobbies which create movements which allow people to become aware of problems and donate and put money, to put pressure on governments to make a change in the world. And I think things are changing. Celebrities are getting on board. There's campaigns, N7 is a link here, you can go on the website. I'm not allowed to play the video because it's a bit depressing and my wife doesn't like it. It's celebrities crying watching the impacts of NTDs in Africa. Unfortunately, I guess it's not quite A-list celebrities. Bono's not there. The only person I actually knew was the guy who played Harry Potter's nemesis in the first 5 films. But there's a sense that there's kind of traction, there's kind of recognition, something's really happening. But before we get to that, I guess we have to ask ourselves, what is an NTD? And what are we actually talking about? And I think when we reflect back on trying to build a sense of NTDs as something that the globe must deal with, that the world must move and rally around, it becomes quite problematic because it's not an exemplary NTD. There's not one thing. There's a whole bunch of diseases. And the reasons that kind of lump them together, that pull them together, are quite different, I think, from the kind of rational reasons we can look at other sorts of disease clusters about. So the group of parasitic and bacterial infections, they're usually endemic in low-income countries, populations in Africa, Asia, and the Americas. There may be ways of preventing or treating them, but I think the kind of notion of access, lack of access, is really central to the identity of an NTD. It may not be possible to gain access to those treatments or those control mechanisms. Some require new tools. We need more research and development, new drugs, new diagnostics, new control measures. And I think burden as well is quite important. One of the problems, I think, from a policymaker's perspective is that the NTDs, frankly, don't kill as much people as other important diseases, HIV, AIDS, TB, and malaria, but they have similar burdens if you take a more holistic view of their impacts and implications, and that's quite important. So, the tropics, particularly Africa, Brazil has a big burden, mainly because it's so big, but there's a clear kind of line delineating the post-colonial world. Lots of these diseases were actually known as kind of colonial diseases, and there's kind of a hangover of that too. So what diseases are we talking about? And that's where I think things get actually really problematic. Plus NTD, which is a relatively new journal which focuses on these diseases, has a very Catholic perception of these diseases. There's 45 plus diseases, plus you can publish in the journal if you're talking about co-infections with HIV, AIDS, malaria, and TB, and also interactions with non-communicable diseases. So a very, very broad perception of what NTDs are. The World Health Organization lists 17 diseases, and we have to think about how do they decide those 17 from a larger number? Were the rational reasons for that? Were there other sorts of reasons? A more recent roadmap for elimination focuses on 10 diseases that will be eliminated or controlled by 2020. And N7, you saw the celebrity grieving photograph just before, focused on 7 diseases. So there's not really a unitary cluster. There's not a group of diseases which really makes sense as far as labeling them neglected tropical diseases. And I think that really creates a big problem. It's basically, to many respects, it's a product of lobbying, of framing policy in particular ways. And that's really the dominant thing rather than any kind of common biology, epidemiology, or treatment. So it's really a policy construct to a large extent. And that makes it difficult, I think, to gain traction in the broader world. So basically, NTDs are clustered because of their human interactions, or lack of them, because they're neglected. There aren't really those sorts of commonalities, biological commonalities one might expect to be. And this creates problems regarding treatment as well. So on the one hand, if we're saying the NTDs are a problem, but it's a very diverse problem, that means on the other we can't say what the treatment will be, which again makes things difficult from a policy perspective. There's not a common way to treat all of these diseases. And I think we risk in doing so creating a set of hierarchies of more and less neglected diseases, some which are treatable and some which are less so. And that's something else to think about too. So to borrow from another portion of science, really kind of paleontology and archaeology, we can talk of lumping or splitting the diseases to an extent. Ones which can be effectively treated, although there's some debate about that, and others which are more difficult to treat, so-called tool-deficient NTDs, according to Médecins Sans Frontières. So tool-deficient NTDs tend to be more complex. They require much more complex disease management. It might be difficult to diagnose. The treatments might require diagnosis. You can't prophylactically treat. And you need quite skilled staff to manage them. And they include things like leishmaniasis, Chagas, and human African trypanosomiasis, which is what my current research is looking on a bit, and certainly there's very eminent people in the audience who work on HAT as well. On the other hand, we have the sorts of NTDs which can be captured more effectively by campaigns like N7. They can be treated through mass drug administration, preventative chemotherapy. You can treat with a single dose. You can cover multiple diseases per annum. They're relatively inexpensive to treat, which is an important kind of policy idea too. Large donations from the pharmaceutical sector means that treatment can be as cheap as 50 pence per person per annum. So there's lots and lots of reasons why tool-ready NTDs possibly receive more attention as a lobbying idea and more attention as a set of diseases to be treated as well. So there's a sense that they're easier, so we can do it, so we should. And I won't read out the names of tool-ready NTDs because I'll get very tongue-tied, but trachoma and schistosomiasis would be 2 of them. I was at a talk last week and I watched Professor Welburn struggle with the names of some of them, and I vowed not to make the same mistake. But possibly the key, the official, the gold standard list of NTDs is the WHO list. And you can see here the broad range of the diseases. On the right, Helminth infections, on the left, a whole range of things, many of which are quite different. So that's the NTDs, this kind of complicated policy construct to an extent. Some can be treated using common control mechanisms, others can't. Some have the tools, equipment to do so, others don't. It's really difficult to grab hold of that. And likewise, the Millennium Development Goals, I think, are in reality quite difficult to grab hold of. So trying to understand the two in relation to each other. We all know the 8 Millennium Development Goals, or I hope we do. Again, they're all set up to be things to allow us to pull resources together, to provide focus, a focal point to development agency, to raise funding, to enhance coordination, to increase collaboration, and drive development in certain directions. And to a large extent, the MDGs have been very effective at doing that. The amount of global expenditure on health and development has gone up remarkably in the last 10 years and continues to do so. But as you might imagine, the focusing of the goals in itself creates other sorts of problems. If you're creating a goal about something focused, you're leaving something else out. And you have this issue of what do you include and what don't you include. And it creates this kind of particularly knotty problem around Goal 6, I think, and the other diseases. AIDS and malaria are encompassed in that, and also to an extent tuberculosis by proxy, and that might be something we come back to. How has tuberculosis been come to see also one of the big three when it wasn't in the goal? And that's quite an interesting thing to think about. So the goals are good at focusing resources, but inherently within that, they're also good at diverting resources elsewhere. So we can talk a bit about the shadows of the MDGs. The disease focus on HIV, AIDS and malaria has been useful for people working in those fields, in particular people suffering from those diseases, but it does relegate other sorts of things. Financial targets have largely been met. There's been massive investment, 22 billion, I think that should be dollars instead of pounds, $22 billion per annum. It's a rare case of a Microsoft product anglicizing something and not Americanizing it. So the targets are being met financially, but the MDGs are not. So it also makes us think a little bit about, well, what are we doing with the money? What kind of programs are being put in place? And also what kind of critiques of those programs are happening? How do we not just create policy? How do we understand what policy turns into practice? And how do we translate the learning back from that into better policy? And that kind of iterative problematic is something which is missing quite often. So I think the MDGs have been extraordinarily powerful and influential. They focused on increased aid, but the impacts and implications are a bit unknowable. It's very difficult to translate $20 billion per annum of health spending into some sort of analysis of health improvements. The world's a very complex place. Another sort of thing we often see in the development sector with increased flows of funding is the increased bureaucratization and institutionalization. And we can also see that in health quite strongly. There's been a proliferation of new institutions, Gavi, the Global Fund Against AIDS, TB and Malaria, a whole bunch of other things, a whole bunch of public-private partnerships, product development partnerships, some of which we'll talk about in a few minutes. But basically this kind of proliferation of new institutions, which is in part designed to provide governance and shape collaboration, becomes incredibly difficult to coordinate, both internationally and nationally. Incredibly difficult for a less developed country to manage all these actors who are doing different sorts of things within the country borders that you may not know about on the one hand, and you may not be able to control on the other. So it creates a certain sense of vulnerability, a kind of unhealthy governance issue, if you like. And it's interesting to have, this paper I think is quite interesting as well. One of the original responses to the fact, the kind of exclusion of NTDs was this idea of creating a global fund for NTDs. This paper published a few years ago. So you can see clearly policymakers and scientists and people really involved in shaping the discourse, the politics of NTDs, were really thinking about how they could latch on to the global health apparatus, the development apparatus. So the MDGs have done a lot of good, absolutely. Financial targets have been met. Success and failure are difficult to attribute, but they certainly shaped aid in a particular way. Vertical, multi-stakeholder, very complex, about partnerships, international partnerships, and probably less rooting in the ground, less rooting in the state than you might otherwise expect. So the MDGs have been both good and bad. And of course, with regard to neglect, there's a real big issue as well. What do the MDGs focus funding on? There's a Lancet report from 2 or 3 years ago now, I think, only 0.6% of ODI, Overseas Development Assistance, for health is allocated to NTDs, despite such diseases affecting at least 1 billion people. So it begins to raise uncomfortable questions around attribution and impact, and who's making the decisions around what we should be spending money on, what we should be doing. And I think the Lancet did a whole series of publications that were looking at these sorts of issues. And clearly the NTD is kind of an example of the kind of well-known kind of 10-90 gap multiplied. But in response, there's been, I think, a really massive movement, the creation of a mass movement, possibly not massive enough that we know more about Chris Froome, or Chris Froome is just one of many particular examples of NTD impact. But certainly in the policy arena, there's a sense there's lots and lots of things going on. Spent about 2 hours last night trying to make this diagram nice, so I hope you appreciate it. I also managed to delete it once, so I'm very, very attached to the idea of an NTD roadmap, at least as a kind of presentational idea. So the term was really coined in the 80s by Warren of the Rockefeller Foundation, so it's an idea which has some history, just as the diseases themselves have a massive history. So there were some thoughts 30 years ago to pull them together, but it was only much more recently, around the turn of the century, when there was kind of a shift towards actually doing that. And what I'm trying to do is to try to give you a sense of basically the diversity of the actors. So the detail is interesting, but probably not that important. I've got an extremely long, dull article you can read if you want the detail of who did what, why, and when. But the interesting thing, I think, is to see this kind of gradual coalescence of different kind of actors in a certain direction. So MSF got quite involved. They established a Drugs for Neglected Diseases Working Group, 2000. The UN MDGs were established in 2000, which, as you might imagine, created a lot of impetus for what might follow that. 2003, the World Health Organization Secretary General said, well, we have to sort NTDs out. There's lots of stuff going on. Nobody's pulling anything together. It's very, very disparate. DNDi and FIND was set up. I'll talk about that a bit later too. There's quite an important meeting in Berlin, GTZ and WHO, around control of NTDs. I should animate it as I go along, just because it's exciting. A set of influential papers started to be published around 2005 saying, well, we need to think about diseases as a cluster. We need to think about rapid impact packages, how we can treat them as a cluster, how we can link their treatment in with other existing diseases, particularly HIV, AIDS and malaria. So we also get the sense of a set of new actors, Peter Hotez, Alan Fenwick, David Molyneux, Lorenzo Savioli and others who start to really push this as a global idea. Commission for Africa was also one of the large influential commissions which mentioned NTDs as important. Second Berlin Commission. The creation of new, this is quite common as well. You have this initial push, and then you have the creation of new sorts of organizations, new sorts of networks and entities. So we have the Global Network for NTDs. US government getting behind it. I think quite interestingly, which you don't, I think, see very much else, the creation of Plus NTD, so a journal that was set up partly through Gates funding, which was dedicated in a way to creating a global community of people working on NTDs, not just on individual diseases, but as part of this global community. So it's partly about knowledge sharing, knowledge creation, but I think also partly about creating a sense of this globalization of NTD expertise. An NGO network, and 2010, the formal identification by WHO of the 17 diseases, which is kind of only the start of it. Since then, things have become a lot more practical, a lot more embedded, a lot more grounded in reality. The WHO launched a roadmap which set targets and deadlines, so in a sense, what you see is a kind of aping or parallel process to the MDGs, and I think by this point, people were giving thought to creating this parallel process with the idea that you could merge things in post-2015 and say, well, we're thinking, we're organized, we're conceptualizing our research and development and drug development and diagnostics development and control in the same sorts of terms as the other MDGs. Therefore, it's really simple to slot us in as a new MDG or part of something in the future. January 2012, London Declaration was launched, which we'll talk about a bit in a minute. United to Combat NTDs in Washington, another London Declaration, WHA resolution, and I think quite importantly, 30th of May, it's seen as something of an important, maybe preemptive triumph. The post-MDG panel talked about NTDs as an illustrative target. So they might actually become a target. And in the appendix of the output of that particular meeting, NTDs were lumped in with the big three as a potential future Millennium Development Goal, whatever that might be called. So you can see two important things then. Excuse me, the London Declaration and the kind of the initial tick that suggests there might be an NTD, MDG, or equivalent in the future. And I think the London Declaration was quite interesting. The last two slides showed this very diverse set of actors, NGOs, international NGOs, not much developing country governments there, it has to be said, but a whole set of important actors. And what the London Declaration did, which I think was quite interesting, is it began to focus things down. So it basically set targets, opportunity to control or eliminate 10 selected NTDs, but no one company, organisation or government can do it alone. So this idea of creating a partnership, but not perhaps the broad partnership the previous two slides would suggest, but instead a partnership which was much more driven by a smaller, more influential set of actors. The biggest bulk of signatories were pharmaceutical companies, 13 pharmaceutical companies, DNDi signed, Bill and Melinda Gates Foundation. The only traditional donors to sign were USAID, DFID and the World Bank. And a very small handful of partners were developing countries themselves, 2 or 3, not more than that. So it's very much a public-private global perspective on how to move things forward, which I think makes sense when you think about the sorts of diseases which are easier to treat. And I think what this does, and this is where maybe I get a little bit too social sciencey, it lets us think about, well, what kind of techniques, what kind of ideas have been mobilized by these actors to create this idea of momentum around the NTDs? Why the success? How was the momentum built? Through partnerships, lobbying networks primarily, but clearly through the deployment of various types of arguments. Counterfactual politics, kind of the logic of synergy, and I think some sort of kind of tip of the hat to kind of rational economics. Basically, it's cheap and effective. So I think counterfactual politics, I think, is kind of best exemplified by the title of this paper here. And this is kind of a technique we see going back to 2000 to the kind of Jeffrey Sachs era when he was trying to build momentum initially for the MDGs. Well, we're talking about vast amounts of money, but in relation to other things we spend vast amounts of money on which maybe aren't a public good, shouldn't we just be spending the money on something else instead? So we focus on something unloved and expensive to make the resource case, and then we focus on the end point, eliminating neglected diseases, and we don't dwell on the process because that's a different sort of thing. So you see policy as a way of setting a target, of setting up an idea of how much money is required, and it almost becomes a kind of tautological argument. You'd be hard pushed to argue against it. Well, nuclear weapons or stopping people dying in Africa, that's an easy solution. And of course, in reality, it's an impossible dichotomy because you can't replace one with the other, but it at least allows people to begin to think about things at a global scale. And we can think also about the kind of logic of synergies as well. The NTDs may not exist in Millennium Development Goal, but they certainly undermine several of the existing goals, and there's quite a lot of literature on that. So if we treat NTDs, we're actually supporting at least 7 MDGs. They will improve. We have more chance of meeting those targets. So there's a kind of bottom-up approach to thinking around NTDs. And also, if you look at other sorts of measures for health, DALIs, for example, there's quite a lot of other sorts of work going on around that at the moment too. Gates Foundation have got endless calls out looking for people who are willing to come up with a better way, a more holistic way of measuring health. These things are important. So a really important selling point of the NTDs is that they are not an MDG, which is quite problematic, I think, but they can play a real role in alleviating poverty. And I think it's a tricky argument because on the one hand, you're cutting across MDGs, saying, well, if we're saying NTGs undermine MDGs, we're saying that poverty is structural, disease is structural, people get sick from NTDs because of the conditions of poverty and underdevelopment in which they live, which is a very different way of thinking about development than that kind of posited by the MDGs themselves. So there's a risk of creating one argument which undermines the ultimate argument you want to make. And then finally, rational economics. Well, it's cheap. We should do it because it's extremely cheap to do it. There's endless talk of low-hanging fruit, of doing it because we can and because therefore it's right. And that's quite a powerful argument as well. So the burden of disease should be the criterion for priority setting, but also we need to take into account what's cost effective. If it costs 50 cents a year to treat one person and stop them getting 7 diseases, we ought to be doing that. Because doing likewise for other diseases, particularly the ones named in the MDGs, are much more expensive and much more difficult to do. So again, it's another, I think, quite a tricky argument to make, because you're saying we should do it because it's easy and because it's cheap. But if it turns out to be less easy and less cheap, you potentially run into a problem and you undermine yourself. So I think the battle isn't yet won. The illustrative target is not yet a commitment. It's the first step towards a commitment, but it's a beginning. But I think the broader question, which I'll turn to for the second portion of the lecture, is really not really if there's a commitment or not, but will a commitment actually do anything? Is a commitment to the Sustainable Development Goals a replacement for the MDGs what we need? And how do we turn that commitment into control? And I think there's three things I'd like to talk about a bit, which I think relate to that and are quite important. So the SDG, the target, the naming of NTDs as a policy idea, as a target, is only part of it. What sort of infrastructure, what sort of understanding of evidence, what sort of capacity would you need alongside that to actually make a difference? And we can look at the MDGs and some of their failings and say something about that as well. We met the financial commitments to many MDGs, but we've not met the developmental outcomes. And that says we have to think again, or think a bit more critically, or think a bit more carefully about how we translate resource into development. So I think the space for NTDs here in the Sustainable Development Goal world, which are probably going to be conceptualized as a little bit broader. So I think one of the likely health SDGs will be called Healthy Lives. And clearly that's the sort of slightly broader concept of health that an NTD focus could fit into. And I think they'll be more interrelated too. So there's possibly going to be an SDG around energy, access to energy, which is also around food, also about healthy environment. So you can see those sorts of more interconnected, less siloed approaches to thinking of development goals would actually fit the sort of way in which we think about NTDs quite effectively. So I think there's a real kind of opportunity there, a real moment in time that can be captured to do something, but only if we translate it into systems and structures and thinking about development in a way which makes sense. So I think we need to think about the evidence base. And the evidence base is shifting, or at least the amount of evidence isn't shifting, but the way in which we think about evidence is changing quite dramatically. There's lots and lots of talk in global health and global development around measurement, data, targets. The SDGs will favour more holistic targets, as I said, and that does create a gap, healthy lives. But I think there's a kind of prevailing notion, an increasing notion that development is about data, it's about evidence. There's definitely a shift towards data, towards having empirical evidence, towards understanding cause and effect, and that potentially is quite problematic. Because what it will probably mean is that quantifiable interventions will become privileged. And I think we can see that in the Gates Foundation. If we think back to, I think it was February, March, the annual Gates letter came out, and he talked very strongly about wanting to measure things and count things, and every progressive business counts stuff. It knows how many things it's made, it knows where they go, it knows how much profit it makes. And vaccines are a good example of that. Vaccines are easily countable. So there's a risk if you're looking towards the more neglected of the neglected tropical diseases, you can't solve problems quite that simply, and that creates potentially a problem. And there's been a recent kind of debate on the internet mainly between Gates and Google, and about whether Google's attempts to do African development are appropriate or not. And this is a quote from Bill Gates: "When a kid gets diarrhea, no, there's no website that relieves that." And he's talking in response to Google's idea of creating a series of balloons floating above Africa, which will give 3G access to the whole continent. And his point is, well, we shouldn't worry about that until we've sorted out malaria. We shouldn't worry about infrastructure and other sorts of development until we sorted out the basic health issues. And I think that's a kind of typical chicken and egg dilemma. Actually, maybe chicken and health, we think about zoonoses. A chicken and egg dilemma when we think about development. Do you treat the outcomes of development, the condition of development, the symptoms, or do you treat the root causes? And I think a kind of turn towards data and development suggests a turn towards targets of interventions and not really engaging with the structural things which perpetuate poverty. And I would argue the structural things, particularly with regard to the NTDs, are extremely important. And I think data represents a real problem for NTDs in three ways. One is a very simple one of underreporting. Underestimation of disease burden is inevitable in sub-Saharan Africa. People just don't know what people get sick from. Some of these diseases are very difficult to diagnose. People might die or not seek treatment long before they're quantified in any way. And I've chosen the example of sleeping sickness because it's a particularly good example here. Underreporting is as high as 40%. Creates a huge problem. If we're living in a world where data is important, where we quantify and stratify and create hierarchies, not knowing how many people get sick from something actually undermines your argument to make a case for funding research or control into that disease. So I think underreporting has been a real problem for almost all NTGs, and there's a couple of papers about this which are quite interesting, one of which has Sue as a co-author. But clearly that we kind of risk undermining the argument for intervention, and also we risk undermining the more neglected NTDs, because the more neglected ones are the ones for which it's harder to collect evidence. And if the diagnostic tools don't exist, they don't, and what can you really do? But clearly thinking around highlighting how we might understand health in a more holistic way, how we might understand health impact in a more holistic way would be good. So thinking more multidimensionally than just death and DALYs, I think, would be really important. So underreporting is one problem. And I think going back to one of the unique selling points of NTDs is the relative cheapness of potential interventions, particularly around the 7 which respond to mass drug administration, is underestimating. I mean, how much resource is enough? And there's a tension, I think, between the kind of low-hanging fruit argument, well, this is a cheap thing to do, and also making sure there is actually enough resource committed to do it. If your uniqueness is cheapness and things start to become less cheap and more complex, you create a kind of policy or resource dilemma for yourself. And I think there's a really fine balance between saying NTD control is cost effective on the one hand, but on the other not underpitching budgets and commitments. NTDs may indeed be low-hanging fruit, but exactly how low, we probably don't know. But in my experience, admitting to not knowing things in policy circles isn't brilliant. So I think current policy talk, current policy chatter is that we require commitment to an extra $2 billion per year to meet the 2020 targets for the 10 NTDs, the London Declaration. That will probably rise, I think. And you can see in this diagram that the current rate of spending, of scaling up, isn't going to help us meet those targets. We need to ratchet up resources, which might happen, it might not. But it's something to consider, I think, when we're thinking about the opportunity cost of making this financial commitment as opposed to something else. And I think the third kind of data issue is really one of optimism. And again, it's another fine line to tread. A perpetual problem of development, I think, is of self-critique or a lack of self-critique. How do you analyse risk? How do you analyse poor performance of your development intervention when in doing so you actually undermine your entire activity? You risk undermining the entire intervention, the entire idea that this approach might be the approach to alleviate poverty. And I think it's particularly an issue we can see with mass drug administration programs in the last couple of years. There's been quite a lot of debate that I'll come to in a moment between social scientists on the one hand and biological scientists and medical professionals on the other. And I think that debate is really problematic. And I think that it's problematic to even think of people as having different disciplinary backgrounds as sitting on different ends of a spectrum. And I think the quotes here are quite illuminating. The top-cited advocacy articles have assumed the effectiveness of mass drug administration for all diseases encompassed. However, we would now encourage the academic NTD field to be reflective and critical about the current policies, practice and impact. And I can't reiterate enough that the sorts of quotes here, the sorts of critiques you see here, are things you see time and time again in the development sector, in the global health sector. This is nothing new. People are trying to create pitches for resources for interventions which will do good. And that's really admirable. But there may be ways in which things could be better. But if there's even the slightest risk that in being a bit self-reflective and self-critical might undermine the commitment or the policy ideal or the hierarchy of your approach as committed and important, then people tend not to do that. And that I think is a real problem. So I think juggling advocacy and evidence presents a really significant challenge. It's a really difficult thing to do. And I think it would also be fair to say that the NTD global policy-making advocacy communities come a long way in a short period of time. And it's competing in a world where the other actors, the competitors, if you like, have got a 15, 20, 30-year head start. They're much more adept at doing these sorts of things. They have much denser, stronger policy networks. They've got more power and momentum behind them. And it's difficult to push your way in and make space for yourself and do so and accept criticism at the same time. So I think diatribe and dialogue is something to think about. How can we be self-critical but also still maintain momentum? How can we incrementally improve things without grinding things to a halt? And it's a real challenge. The paper at the top was a publication that came out 2 years ago by Tim Allen and Melissa Parker. And what they did was they looked at some of the other diseases with MDGs, and they looked at the kind of end point of mass drug administration programs. And they found problems. They said, well, people aren't actually taking the drugs. Sometimes school children are administering drugs in schools. There's kind of issues with the whole thing. And I think probably the mistake they made in retrospect was to kind of create a global argument out of a small amount of ethnographic material created from a small number of villages. And they kind of spun their paper's argument to be that, well, we must now consider evaluation as the top priority in global health. These examples show where there were failings or maybe a lack of success or maybe over monitoring or over-exaggerating success within Uganda in particular. We must take these to mean, well, we need to think more holistically about mass drug administration. And I think the second quote caused a lot of problems. A commitment to combating neglected tropical diseases is a hugely positive development, but that is all the more reason to avoid treating fundraising rhetoric as fact. And I think that particular quote created a lot of problem within the community of people who are advocating for the NTDs. And you can see with the sorts of responses, an article by David Molyneux, which in essence was a critique of this argument. Factual errors which call into question the credibility of the authors, unethical and grossly negligent. Worst, it is damaging to poor people who benefit, could lead to donors withdrawing much needed funding for a massive programme. And I think there were some factual errors, the most glaring of which speaks to something I raised earlier, is the fact that in the paper, Allen and Parker talked about MDG 6 as being the Millennium Development Goal for HIV, malaria and TB. And actually TB is not part of that Millennium Development Goal. It's been subsumed in through the Global Fund. But this kind of point was picked up on by Molyneux and colleagues and said, well, if you get this kind of simple thing wrong, the whole argument's undermined, which I think is fallacious. I think it's not a great way to have a constructive debate on the one hand, but it also does show how with effective lobbying, you can insert other sorts of diseases into important bits of global development apparatus. So I think we can say, well, they're coming from different disciplinary backgrounds, they're talking at cross purposes, and that's really true. I think there's also an element of how different disciplines understand evidence. For a medical anthropologist, I think looking at one case and saying, well, this case means we need to think problematically about other cases is perfectly acceptable. That might be different for a public health, a global health person. So there's some issue there. But I think ultimately it's really problematic because I don't think either side of this debate are arguing for anything different at the end of the day. They're both saying, yes, we need to engage with and treat neglected tropical diseases. What they're saying is, I think on the one hand, is we need to think a bit more about how we can do it better. And I guess on the other, it's partly about the global lobby finding a way to compensate and pull in the slightly divergent views as well. Because I think you build strength through capturing that diversity by building a real interdisciplinary sense. I think it speaks to two things then. It speaks to the highly political nature of development funding. A huge amounts are at stake. DFID have committed 250, 260 million over the next 5 years to funding primarily to funding mass drug administration schemes. They're huge, huge investments, massive investments, and they will treat a lot of people. Maybe not as many as might be hoped, but certainly a lot. That's not to say we shouldn't still critique those investments and critique how those programs are run. And I think that's really important. And I think it also shows how we have to pull together different sorts of intellectual communities, whether it be academic communities, social scientists and health professionals, or policymakers. But I think it's in pulling together those divergent views and saying, well, how can we articulate a way forward to create proper engagement? I mean, that's how you create a more sustainable engagement with NTDs as a policy idea and as a set of diseases to be treated. So that takes me to, I think, the second key thing, which is really about new tools. How do we create innovation for tool-deficient NTDs? If we need new drugs, and we need new diagnostics, several hat drugs predate World War II, for example. They're highly toxic. We need more of a sense of more momentum within the product development pipeline. How do we do that? We need to create incentives, but we're talking about diseases that are neglected precisely because the people who suffer from them have no money. So we have to create proxies for markets. We have to create other sorts of incentives. We have to drive innovation through other sorts of parameters. And a key thing, a key development has been the development of product development partnerships themselves, the International AIDS Vaccine Initiative, driving to create a vaccine for HIV, ARIS trying to create a vaccine for TB, have been really massive investments, very, very product focused, very linear in terms of how they go about pushing research and innovation for developing new drugs. And they're a key way, they've become a way to leave a private sector interaction by taking some of the risks away and funding away those risks through public sector investment. So on the one hand, we've had these large public product development partnerships, public-private partnerships. On the other, we have a sense that through Gates Foundation, through the ways in which the bilateral, multilateral donors have been funding research, we have more complex research consortia, multi-country, multi-partner organizations that pull together different expertise from different parts of the world. Basically, they aim at building collaborative research, more holistic research. And I think one thing we ought to think about, again, being a bit more critical about things, do these sorts of approaches which focus on single products or collaborative partnerships often driven by northern partners, do they actually narrow innovation pathways or do they generate more innovative opportunity? And I think that's also quite important. We need to generate innovation around the margins or below the radar, not just innovation through the idea of global health and global vaccine development. So this is where my talk gets quite sketchy, because this is actually research that's been led by a colleague of mine in the big project looking at trypanosomiasis. But what this diagram, this social network analysis is designed to do, it's designed to capture co-authorship of articles just around sleeping sickness, just around trypanosomiasis in a 3-year period. And it's a 3-year period because we wanted to capture the beginning point when the Millennium Development Goals started as a moment in time. And also because, frankly, there's too many publications coming out and we don't have the software to capture everything. But we can see already this, what we've tried to do is to the kind of store of in-betweenness and centrality catches what you might consider the most connected gatekeeper organizations, the organizations through which the most research partnerships and research publications flow. It's organizations you might well expect. Swiss Tropical and Public Health Institute, Institute of Tropical Medicine in Antwerp, University of Glasgow, London School of Hygiene, Tropical Health, World Health Organization, Medicine Sans Frontières, which is probably the unusual one. But I think it's quite interesting. It gives a sense of there being a small number of organizations who basically control a lot of the way in which research is conducted and shape the publications. Coming forward to 2009, 2012, you can see quite different things. You see a lot more publications, clearly. The density, the complexity of the graph, of the diagram just reflects more co-published articles. But you can see different sorts of actors. So the top 10 in the previous list of gatekeepers, the top 3 are still there: Swiss Tropical Institute, Glasgow, and Institute of Tropical Medicine. Edinburgh's there now. The Ministry of Health for Uganda is there. Makerere University's there. University of Sao Paulo's there. So you're seeing a bit of a shift. You're seeing, I was going to say developing country universities, but I should exclude Edinburgh from that possibly. You see Southern Partners becoming a bit more part of this network, this kind of global publishing research network. And I guess there's 2 hypotheses, one of which is that enhanced funding streams have driven more publication, and another is the emergence of new organizational forms. For example, the Gates Foundation are very keen on research consortium, of funding organizations as part of a package of 6 or more partners who do different things. And it's difficult to match the 2 up. But clearly the form is almost certainly the case. The latter, I think, is probably the case when we consider that the Swiss Tropical Institute and Institute of Tropical Medicine have long been recipients of Gates funding. So they almost act as gatekeepers to Southern Partners to become involved. But I guess we have to ask ourselves, is this really creating more diversity, or is this just creating more publications amongst the same sorts of organizations? I mean, the spread of the graph actually indicates a sense of the diversity of the research institutions. Unfortunately, we've not quite managed to map it onto a map of the world, which is far more complex than you might imagine. I thought you would click a button, but I'm used to Facebook. But if you were to do so, you can see there's actually almost more diversity then, and there's almost a pulling in of publications here. Certainly more activity being done, more research happening, more publications happening, but in a smaller number of organizations, although a different set of gatekeeper organizations. And I think that idea of gatekeeping is quite important. We're trying to show that we're spreading research, we're spreading capacity building, we're reaching outwards, we're thinking of innovation as a broad thing, not a narrow thing. And I think there has been shifts in that direction. The organizations at the bottom, I would argue, are not product development partnerships in the sense that the International AIDS Vaccine Initiative is, where it sets out to fund organizations to develop an HIV vaccine. They're more like brokers who've been outsourced by bilateral donors or empowered by foundations like the Gates Foundation to make decisions and prompt research and prompt new avenues of research. And I think because they're brokers, they're not organizations who do these things themselves. They can actually, I think, be a bit more cutthroat. They have less vested interest. They can pull the plug if things don't work, or they can pursue new avenues if they so choose. And that's something not really available to universities or in particular Southern Hemisphere research institutions who've got 20, 30, 40-year tied-in histories of doing particular kinds of research. So I think there's some innovation there potentially. Although that innovation, I think, partly because of the way the donors fund things, is being limited to an extent. There's definitely a mantra of new products. So taking GalvMed, for example, who focus on, our interest in them is looking at various drug developments around trypanosomiasis. Gates give them a massive amount of money, as did DFID, but they have to produce a new product. They can't produce a more effective, more appropriate version of an existing product, because that doesn't keep the Gates Foundation happy. So there's definitely a sense that it's a certain kind of innovation, a shiny, new, brand new innovation, not a refinement of things which might work but could work a bit better. And some donors just aren't interested in access. So Gates don't fund these projects with any intention of worrying about how drugs will get to market. They set up licensing agreements so drugs aren't too expensive, but they always work on the assumption that the private sector will just make things happen, which isn't always the case. DFID would have a different perspective on that. And my sense is that an organisation like GalvMed struggle a bit to juggle the different donors' perspectives on how to make innovation work for product development. So that brings me to, I think, the last point I'd like to make, which is really around institutional capacity. I think the one set of actors which have been almost absent, almost missing in the whole discussion, the whole talk so far, is the state. and I think the state is very important. It can't be bypassed, even if the capacity is limited. Clearly it can be bypassed, but it shouldn't. And I think engaging with the state is important if we're going to create sustainable networks and systems through which we engage with NTDs. The private sector is clearly important, but the private sector has to do things in partnership with the public sector, especially in resource-poor, market-redundant developing countries. I mean, that's really essential. And of course, the state in Africa in particular has a really problematic recent history. Structural adjustment programs in the 80s stripped capacity out of the state, particularly with regards to health capacity, veterinary capacity. State capacity is often quite weak, it's diffuse, it's fragmented, it's decentralized. State doesn't necessarily have the capacity to coordinate and pull together activities. And I think that's a real problem. And the case study here is really just, it's very recent research we've been writing up from work earlier this year. We were basically speaking to people who were charged with engaging with Medicine Sans Frontières when they had a succession of missions in northern Uganda, right up on the, well, what's now the South Sudan border. I should have got an up-to-date map, clearly. And there's a sense of MSF coming into the country and doing stuff and leaving, and coming in and doing stuff and leaving. An MSF, as an international organisation, were basically setting the parameters of an emergency. They would decide when an emergency was happening, they would decide when the emergency was finishing, and they would just go. And there was essentially no engagement, or very little engagement, with the Ugandan government, which didn't build any capacity, which I think left quite a sour taste. So one of the quotes from an official in the Ministry of Health was, well, they extinguish the fire, then they go. They don't leave anything behind. They don't leave any resources for us. But of course we can't refuse because we don't have the capacity ourselves. So the state ends up being in this quite subservient, powerless relationship with international organisations. And I think it does speak to a particular idea of an NTD engagement as an emergency. You kind of, MSF instinctively prioritises the present over the past and the future. Whereas I would suggest that quite a lot of the best literature, the best programs, and the best thinking about NTDs involves placing NTD control in a historical context. And in fact, people in this room have written quite a lot of this. And I think that's something that shouldn't be lost, but risks being lost in the globalized, internationalized world of NTD intervention. So one final idea, one world, one health. It's kind of an emerging idea, really emerging out of, I guess, the kind of threat of global pandemics around avian influenza, bird flu. And it basically is an idea that suggests we should have more convergence between human, animal, and ecosystem health. And clearly, particularly for the more neglected NTDs, like human African trypanosomiasis, where there's a zoonotic component, this makes a lot of sense. But again, if you look at the sorts of perspectives of people in the developing countries, in the organisations who, in a way, are playing a one world, one health role, they're meant to pull things together and coordinate and prioritise activities. They don't feel part of this. You could argue the work they do predates this global idea of a one world, one health policy perspective. They've been doing this kind of work for a long time with limited resources. Quote from Uganda. Fine, we need to eliminate, but as long as there's no clear mechanism or mechanisms for sustainable control and resources, especially financial resources, we're just joking. Some of the partners prefer dealing with certain institutions and they don't work within established coordination mechanisms. Likewise, Kenya. There are too many networks. Everybody is doing everything. We need to come together, but there's too much fighting over too little money. And again, there's a sense of donors, the way the donors fund things in fragmented, contradictory ways, also creates conflict and tension. So a key thing to think about then is that intersectoral approaches need to be rooted and coordinated, rooted in the state, rooted in the places in which these diseases affect people, and also coordinated in those countries with strong connections to the international partners and networks. And that suggests, I think, a whole set of other sort of funding priorities alongside mass drug administration, alongside research and development and product development for new diagnostics and diagnostics and drugs. So I think my final point would be that it's really a point about good donorship. We can talk very much about the ways in which scientists behave, policymakers behave, the way in which we can kind of create networks of people who lobby and advocate for certain things. We can critique and problematize all these approaches to greater or lesser degrees. We can critique the capacity and efficiency of the African state. We can worry about the market. But ultimately, it seems to me, in an arena such as this, in a neglected arena, the donors drive so much that actually the donors should be the organizations, the funders should be the organizations who think about the implications of what they do. The impact of their decision-making, of their policy-making, percolates down through the entire system of research, control, of product development, and that's really important. Percolates down to health systems too. So I think we need to move away from thinking about the MDG silos to maybe One Health systems, and we need to think about complexity too, politics, history, biology, all these things in connection. We need to think about what evidence does. Evidence should support the decisions we make, not drive them, because we prefer a different kind of evidence over others. Tools should encompass policy, practice, and technology. Either is lost without the other. And institutions need to be built through coordination, not competition, not through scrabbling for the same funding, but applying for the same funding in partnership and encouraged to do so. And I think there's a quote here from a National Control Programme official, which I think is quite poignant. A heart resurgence is going to happen. Give it 10 years and it shall be business as usual. So just because things may be on the road to elimination or may not be apparent now doesn't mean they won't be in the future. And I think that kind of leads to the kind of misquote that control needs to lie at the heart of all development, as does global health more generally. Thank you very much.